Good morning. I'm Dr. Ken Williams, Chair of Medicine here at the University of Louisville. And we are pleased this morning to have a wonderful internal medicine grand rounds that's focused on rheumatology. We're going to be hearing today from our assistant professor and veteran specialist in military medicine, a gentleman with a strong history of supporting our veterans, Dr. David Armstrong. And I will turn over, as I normally do, the introduction to our leader in rheumatology, Dr. Hussam Sarakbi, who has been with us now almost a year and came to us from Wayne State. Really happy to have you and happy to hear your introduction of Dr. Armstrong talking about chimeric antigen receptor, a T-cell therapy for autoimmune disease. Thank you, Dr. Sarakbi.
Thank you. Thank you. Welcome, everyone, and glad to have you all attending rheumatology ground round with the Department of Medicine. So, to introduce Dr. Armstrong, Dr. Armstrong completed his rheumatology fellowship through the Army at the Walter Reed. He had performed bench research with lupus mouse model, studying cytokine and chemokines, profiles and clinical research for prevention of ventilator-assisted pneumonia. He served 14 years in the Army, and then he deployed to Iraq as a flight surgeon. And after his military career, he joined the University of Colorado for 6 years before moving back to East to be closer to family. He's currently serves as Chief of Rheumatology at Ravi Rex and as a Fellowship Director for Rheumatology at UofL. Glad to have you, Dr. Armstrong.
Well, thank you both for the kind introduction. Really appreciate it. And I know it's a mouthful, the chimeric antigen receptor, so we just like to abbreviate that as CAR T therapy. And that'll be our focus today, not only for rheumatology, but for other autoimmune disease out there as well. And we'll talk about the additional applications that you may be thinking of already in different sessions. So we'll start with our learning objectives. Really, we're going to discuss the big problems that we have with refractory rheumatic disease. And I get these questions all the time as to what Dr. Sarakbi and I would do when things go badly. We'll also review our current approach to treatment and kind of assess how we use medications and therapy and where the gaps are in that treatment. And then we'll look at understanding the history, application, limitations, and also the serious side effects of CAR T therapy. And then we'll discuss the plans for future use here and in rheumatology. So I have to give my disclosure for the VA, and once we give that, then we can have some fun and have some jokes, because it's going to get very serious with some in-depth pathology and pathophysiology, immunology, pharmacology. But don't worry, you won't be overwhelmed by these topics today. I will try to keep it light. And I have some videos for video folks that want to understand these therapies a little bit more in depth, the hyperlinks, so we won't play those, but I have a lot of graphics, pictures, and animations to keep it light and understanding for everybody. And then I really want to give thanks to Dr. Mirza, who did a short VUMEDI video presentation on CAR T therapy for the application in autoimmune disease, and really framed this lecture for more in-depth learning for you all, but made a good template for me to help utilize to explain it better, because this is a newer therapy to us. It's been around in cancer for quite some time, but really to us, very new and on the horizon, and we'll talk about how that's going to work. And I really want to send a thank you to the list of other folks out there who helped me with research early in my career. Had no idea that when I was cutting up small mice and making gels and blots of organs, how much that research would contribute to what we know about autoimmune disease and lupus today. Like double-stranded DNA is associated with nephritis. Complement 5 is very bad with antiphospholipid antibody syndrome, but I had no idea that my participation in that research would cause such changes. Same thing with ventilator-assisted pneumonia and raising the head of the bed. Had no idea that that would become standard of care. I was just a spit guy that had to put radioactive dye down NG tubes in the ICU all the time. But really, I would encourage you all to participate as much as you can in research because you never know how much that's going to change the world or medicine in general. And I also have to disclose that I was a former owner of CRISPR therapeutic stock. I sold this because of a conflict of interest with the VA and my involvement in the pharmacy committees. But we will mention this during the course of the lecture today. So I know the theme earlier in the year was about mentorship. So I'm going to continue that theme. And really, the U.S. Surgeon General has said loneliness is an epidemic. Is a cardiovascular risk equivalent of smoking 15 cigarettes a day. That's pretty crazy. And guess what? I came across a quote from Dr. Ornish, who came to speak with us earlier in one of my podcasts. And, isolation and emotional stress are risk factors that are modified. So what I would tell you is being a good mentor and having friends within the medical community is good medicine. So what are we doing in rheumatology? Everybody wants to know that. I send my 5 things once a week to the boss through email. It's great. I've taken a positive perspective on this. It's awesome. Everybody always wonders what Dr. Saraki and I are up to. Now I get to say on a weekly basis to my boss and the big boss what I'm doing and how things are going. It's great. I love it. And so Dr. Saraki, who introduced me, thank you again, sir, is really revamping the department as chief and really bringing research back to the university as we start the fellowship program. And great news, we're going to have a fellow this coming year. Dr. Buchan from Wayne State is going to be our first fellow, and we're still looking for staff and doing a hard job trying to find additional staff to rebuild the program and make rheumatology strong again here at University of Louisville and in the community. All right, so I love lectures that start off with, have you had this patient, right? And that gets you on the edge of your seat because you're like, oh, I've had that patient, or I've seen them in the ICU. But what we're talking about here is recalcitrant autoimmune disease, insert disease of choice, psoriasis, inflammatory bowel disease, myositis, vasculitis, multiple sclerosis, whichever disease you choose. We try conventional therapy, doesn't work. We try advanced therapy, they have side effects, doesn't work. They want to go see a major tertiary referral center like Mayo Clinic, Cleveland Clinic to get advice. They don't get any additional advice and they come back to us hopeless. It's very frustrating. We look at clinical trials on NIH website. Is there anything possible for this patient we might be able to improve their quality of life? We can't find anything where they're not eligible. And you have that sinking feeling that you've done all you can do and there's nothing more. And hopefully we're able to change that sinking feeling with regards to these diseases in the future. So I started this way before the flooding. So I really like this. When the winds of change rage, some build shelters while they build windmills. So I guess with the recent flooding, we could insert sandbags and an arc. But I think, really that's been our frustration. We don't have choices for these patients that are quite refractory to everything that we know of. What can we do? And that's when people get creative. I see people getting creative, combining biologic therapies, injecting a biologic subcutaneous injection into a joint. We see people getting creative and using off-label treatment when we don't have hope. So Dr. Saraki and I have 265 problems, but I'm only going to really focus on 2 today where we see the most problems. Systemic sclerosis, which is a very dismal disease with limited treatment options and end organ manifestations. And we talked about this before previously with interstitial lung disease. Dr. Kathari also brought up pulmonary hypertension associated with systemic sclerosis and other autoimmune diseases, and a lot of treatment that's not great and a high mortality rate. I've been asked, will immunosuppressive or other treatments affect that type of pulmonary hypertension? We're not sure, we don't know, but Dr. Kathari and I think that it may, and we'll explore how CAR-T may help benefit this as well. And then we all have the lupus patients that have bad disease, whether it's kidney disease, CNS involvement, where we want to do something different. We use our standard treatment, but then they have a lot of problems, especially if we can't catch disease early. And I really, there's been some study in CAR-T therapy and refractory disease with idiopathic inflammatory myositis, really, I would say the one form of myositis that gives us the most problems is the MDA5, which we talked about last year as well. It's a very bad myositis and will destroy the lungs very quickly, despite even our most aggressive immunosuppressant therapy and treatment. Now, there's others out there. We have attendings always approaching Dr. Sarapi and I with, what would you do for this refractory EGPA patient, GPA patient, vasculitis patient? And a lot of times, those can be a problem, but for the most part, I think as long as they're in a healthy enough state, they don't have comorbid infections, we have pretty standardized treatment options, but there are definitely patients, 1s and 2s, with much rarer diseases that fall outside of our normal treatment paradigm and don't respond to therapy as well as we'd like. So I can't cover everything, but we'll focus on the big topics of diseases that we have the most difficulty with. So we talked about systemic sclerosis and the problem with the three-pronged attack. We have injury to the endothelial cells, whether it's with the distal cells and capillaries in the hands, where we're getting ulcers and critical digital ischemia, whether it's with the kidneys, the lungs, or with pulmonary hypertension. And then we have activation of the innate and adaptive immune systems, and then fibroblasts come in. They get recruited and start laying down fibrin, which causes skin hardening and hardening of the other organs. And really, as we talked about this before, I define it as a microvascular inflammatory fibrotic disease. It's bad, but it comes at you from 3 angles. And, I think well-liked was my analogy of the whack-a-mole, where we take care of the scleroderma renal crisis, and that's been soul crushed with the utilization of captopril when this occurs. But then what happens? We have an increase in other diseases, particularly pulmonary arterial hypertension and pulmonary fibrosis. Those come right back up. So we treat one component of the disease and others take precedence. And then what happens? Well, I have the 30% rule. 30% of folks over the course of 10 years will develop serious life-threatening complications of systemic sclerosis with a 30% mortality. And so we have a dismal disease, poor outcome. 1 in 3 patients will succumb to disease over 10 years. And even with our very best treatment, bone marrow transplant, there's a high mortality, 30% mortality. So the question is, are we selecting patients that are going to get better, stay the same, get worse? Or if we gamble and try to treat them super aggressively, they may die anyway from the treatment. Not a great, happy outcome. But there's hope, and we'll talk about it. Systemic lupus. So it's a preventable disease. If Dr. Sarapi and I are able to identify these patients very early in disease and start hydroxychloroquine, even with high-risk features, low complement levels, elevated double-stranded DNA, we're able to stave off and prevent end-organ complications. And we see that all the time. I have a clinic loaded with patients who have been started early on hydroxychloroquine, never developed any end-organ involvement, particularly nephritis. But what are we seeing in the hospital and in the nephrology clinic? Patients who are not caught early with end-stage disease and renal involvement. And that's, we talk about checking the ANA. You'll run into a lot of rheumatologists who begrudge checking a positive ANA. Statistically speaking, about 1 in 20 to 30 patients I see that are referred for a positive ANA will have systemic lupus. So feel free to check. As we educate the future generations in internal medicine, yes, check the ANA, but if you're highly suspicious, check the double-stranded DNA, the complement levels, the CBC, the urinalysis, the antiphospholipids to get a clear picture and early diagnosis of lupus rather than just checking a non-specific test. Know what you want to check. Additionally, to diagnose disease, catch it early, and really provide a great long-term outcome for patients at high risk for complications. So what's the big mortality from renal? It's from renal disease. And that's what we see 3 to 5 years after diagnosis. It's 19% of all mortalities. So those are the patients you're seeing that get very sick. They have delayed diagnosis, whether marginalized healthcare or otherwise, or people just aren't checking the right labs. There's proteinuria on the urinalysis, low blood count, someone checks an ANA. And then unfortunately, because of the paucity of rheumatologists, it can take 1 year, 2, 3 years to get in with Dr. Sarapi or I, and then they've already developed end-organ complication. And guess what? And for Dr. Williams too, lupus is a cardiovascular risk limit, as are most autoimmune and rheumatic diseases. And it's implicated in cardiovascular disease in 61% of all-cause mortality with lupus patients. So catch it early, know the right test to check, but if we've missed it late, we have some options too. So what have we been doing? This is going to get in depth with the pharmacology, but I'll include some jokes so we have some understanding of what we do. All right, so first we use corticosteroids, right? We use steroids for everything. All right, don't know what's going on, there's inflammation, let's use steroids. Or let's call up Dr. Saraki or Dr. Armstrong and say, hey, can we use steroids? As long as it's not an infection, other risks. Sure, you can use steroids anytime you want. What do the steroids do? They affect NF-kappa beta, and then they stop interleukin-1, as I like to refer to it as the dark overlord of all things inflammatory. And my personal favorite from reading a literature review on corticosteroids recently, the author referred to corticosteroids as Satan's little helper, which I think is wonderful. You know, everybody loves steroids till they have the complications, and then the endocrinologist, everyone else, oh my gosh, all the complications, right? So they're good, but they're a Band-Aid treatment. Can't use them long-term. They have a lot of risks. And really, I would say Dr. Saraki and I spend a good deal of our time trying to get patients off of steroids because they have the side effects of Satan's little helper. All right, so we start steroids. We try to get patients off steroids. Then what we do next? We use disease-modifying anti-rheumatic drugs, hydroxychloroquine, azathioprine, methotrexate, what have you. Most of these drugs are so old, we still don't even know how they work. And we talked about that with methotrexate. How would you like to use a drug, which is our best drug for rheumatoid arthritis, for 60 years and still have no idea how it works, but guess that it works to a density? That's scary, right? But they do seem to work. They affect the immune system. They have some toxicities and risks, but generally low risk overall and work very well. Hydroxychloroquine, our best drug for systemic lupus. Methotrexate, our best drug for rheumatoid arthritis, and they induce remission in a large number of patients where we don't have to do anything else if we catch disease early. All right, so that doesn't work, right? So then what do? We have options. We can inhibit the B cell. Lots of targets on the B cells. I think everyone is fairly familiar with rituximab. We use it for a variety of implications, cancer, autoimmune disease, affects the cluster of differentiation 20. But there's other targets out there that you may not have heard of that B cells, are affected by. All right, so that, other disease processes we don't use rituximab for. So what do we use? We use what I refer to as the CEPs, the MABs, and the NIBs. So they all have different targets, whether they target the fusion proteins, they're monoclonal antibodies to different interleukins or leukocyte sites, or they affect the kinase enzyme itself. So they stop the immune system to a large degree. All right, so still not working. Okay, what do we do then? We have other options, especially if it's an immune-driven process, it's antibody-driven. So we either give you a bunch of antibodies that confuse the immune system with IV immunoglobulin, or we take and get rid of the bad humors with plasma exchange. So another option. And these are just things that we're doing. All right, so that doesn't work. And then the big question comes up to Dr. Saraki and I, what are we going to do? Should we use Cytoxan? It's always a big question because there's a lot of risk with it. You give it once, we're giving essentially mustard gas, which alkylates, DNA, either in an IV or oral form. Give it once, causes sterility, lots of other problems. And the thought is, we're still not sure completely how it works again, that it modulates Treg cells or T regulatory cells and doesn't cause programmed cell death like cancer. So we're using lower dose than we use for chemotherapy, but we hope it affects the immune system. Still not sure how it works, and it has a lot of risk. All right, so that fails. Then what do? We're out of options. So let's try to hard reset, press power off on the computer, the immune system by doing a bone marrow transplant. But there's a lot of risk with that. Graft versus host, death, complications, infections. Or we take out the organ and replace it with another organ, whether it's a mammalian or pig, or another human donor. We replace the lungs or the heart or the kidneys, right? And that has some risk too, and there's a limited amount of organ donors out there. That's what we've been doing. That's our current thought process. Is there something better? All right, so I'm gonna do a flashback. We're gonna do some tie-ins to my other lectures to make it important how small changes in science and knowledge will affect how you think and what we do in the future. So I did my rheumatoid arthritis lecture a couple years ago. Talked about these prime cells, circulatory fibroblasts. They migrate out of the synovium when there's a flare. right? So are we thinking like autoimmune diseases like cancer? The big take home from this, which I found with the CAR T investigation presentation today, is guess what? Leukocytes move and hide. And where do they hide? In organs. And we can't get to them with our standard therapies, right? It's a fascinating concept. And where do we see them hide the most? Guess what? In skin. They hide in skin. And what are some of our big manifestations with systemic sclerosis and systemic lupus? Skin manifestations, right? So B cells are moving. We target systemic therapy. We get rid of those B cells with a variety of different treatment options, but they're hiding out. So this is a beautiful image of a leukocyte, and little whirlybird butterflies or antibodies floating around a leukocyte. I just thought this was wonderful, and I wanted to include it in the lecture. All right, so we're still going to use the windmill analogy. So is this an inflection point in medicine with using CAR T therapy, and is it going to be the wave of the future? Are we building the windmill when the winds come and we don't have treatment options? Or are we going to be like Don Quixote, chasing down windmill giants like a knight, misguided and in his travels throughout the world? You know, I would say probably the former, right? We have found a way to treat bad disease that doesn't fit with how we currently manage autoimmune or rheumatic conditions. All right, so we'll get to the meat of the lecture. And there's a lot of immunology and interleukins and CDs coming up. So we'll try to keep it light. We'll end a little bit short today, which I'm sure there won't be complaints on. So CAR T therapy. We're going to talk about the history, how we apply it, its limitations, and then what we're doing here to bring this therapy on board at UofL. All right. So here in the center, you see the CAR T cell itself. It's a reprogrammed T regulatory cell. It has attack molecules on it, and we'll get into this in detail. But this is how we really use it for cancer, right? We take a white blood cell, a T cell, is regulatory. We add stuff to it, and then we make it into a tank that attacks cancer. And it does a great job. It's amazing how it works. So where did CAR T come from? You know, there's a great video I included for the video folks below if you want to click on the hyperlink after the lecture or screenshot it. So a lot of it came from research of HIV. A lot of funding. HIV is a bad disease. You know, popped up in the 80s. We had a lot of funding. But what was the trouble? Again, leukocytes hide. So we give antiviral therapy, hope that it cures things, but guess what? Then the virus comes out because it replicates within white blood cells itself. So really difficult. But they posed the question, can we get to deep-seated leukocytes and treat those so that we can eliminate HIV? Great concept, right? Then we have the gradual development of CAR T therapy. And Emily, patient number 7 from my hometown of Philadelphia, CHOP. She has refractory ALL, failed 2 treatment courses. There's no hope. They enroll her in a clinical trial for CAR T. It's curative. She just turned 22, I believe. So she's attending college. Hope was dismal for her. She was the first child to receive CAR T therapy with a miraculous outcome. And when we talk about miraculous outcome, it just happened to be a happy series of events. So she developed a severe reaction afterwards, a SIRS syndrome, fevers of 106. They thought she was going to die. One of the researchers said, hey, we just started a medication called tocilizumab for my child who's a year older than Emily, and it has a profound effect on systemic inflammation. Do you think we could try it because we don't have anything else? And they tried it successfully, and she survived. And now we use it all the time. And right, we're real familiar with tocilizumab. It was an IL-6 inhibitor for SIRS syndrome associated with COVID, right? So we keep applying this knowledge to other disease processes. But this is a great link between cardiology and rheumatology where we're using others' therapies to the best of our benefit to make patients better, but really a miracle. And thanks, Dr. Clover, because he really introduced me to the Song of the Cell he had an article in the Louisville Medical Journal where it's a deep read for those who like deep read, but a history of our knowledge of cells and immune systems. And they start off with, you know, reporting the case of Emily, which was fascinating. And we heard some snippets of CAR T therapy being used in rheumatic diseases. I'm like, this is fascinating. And great, there's a rheumatology tie-in. What could we use this application for? That's my excitement phase. All right, so then we start with a case report. So for those of you out there, specifically residents, who are like, I'm just doing a case report. They had a great, and a rheumatologist, a great article recently talking about the importance of case reports. So I think a lot of people are like, well, no, it's just a case report. It's a unique finding, everything else. An author said, where do you think we found antiphospholipid antibody syndrome? It was a series of case reports of females trying to get pregnant who had multiple miscarriages. And guess what? That led to our knowledge and investigation of antiphospholipid antibody syndrome. So, although you may not feel that a case report is glorious research, it can provide life-altering, medicine-altering, diagnosis-altering evidence for others to really change the way that we practice. And that's really what happened. I think, the joke with the case report is, how many times do you see a case report in a New England journal? Not a lot, right? They do a case review, but a published case report, you don't see it a lot. So this is our lupus patient from Germany with the worst lupus. We got nephritis. It's active. Nephrotic syndrome, so 5 grams of protein a day. Pericarditis, pleurisy, rash, arthritis, antiphospholipid antibody syndrome, and ligament sacks, right? This is the slam dunk of lupus and all of its manifestation. So then we go through our treatments. Same thing we talked about earlier. Let's try some hydroxychloroquine, our best drug. Probably a little bit too late in the game. High dose steroids, Satan's little helper, lots of problems. Let's use an alkalizing mustard with cyclophosphamide. It's a 20-year-old, so we're going to make her sterile and also pose the risk for renal or bladder cancer lifelong right off the bat. All right, let's try mycophenolate or cyclophosphamide light. Let's try tacrolimus. None of that's working. All right, let's try B-cell therapy, multiple B-cell therapies. Nothing's working, right? So I reference back to that patient where we have no options. We're at the no option stage, right? I mean, I guess we could transplant a kidney. We could do a bone marrow transplant. It does have some significant risks. But there's other organs involved. It's not just the nephritis. So what do? They're like, we're out of options. Let's try CAR T therapy and see what happens. So I got some errors for this one. Double-stranded DNA antibodies plummet. They're gone. Right? That's one of our key biomarkers of active lupus, double-stranded DNA. Complement 3 goes up. That's terrific. It's an immunoglobulin production and complement fixation state with lupus, right? So if complement's coming up, that's great. We're not fixing complement because nothing good happens when we fix complement. We'll talk about that a little bit later. Complement 4 comes up. That's our biggest biomarker of risk in addition to the double-stranded DNA. Proteinuria plummets, gone. And guess what this means, right? We have all the biomarkers, but our SLEDI, which is how we look at, a systematic, organized approach to disease activity with lupus, plummets. It's 0. Works great. But it's a case report, right? One study. But what happens in one study? It builds momentum, builds knowledge, and changes our practice. So what's the problem with the immune system, right? With autoimmune disease? So there's lots of problems, and talk about autoimmune disease of choice on the left. I also added myasthenia gravis and idiopathic inflammatory myositis because those have been looked at with CAR T therapy specifically. All right, so big problem with B and T cells that don't get along, right? And it's a reciprocal negativity. Once one goes bad, it encourages the other to be bad, and then both are bad. And that stimulates the immune system to start attacking the cell. What else happens? Oh no. All right, so we get antibody production. We've talked about that. And then we have micromolecules, interleukins that get produced. And then heaven forbid, complement gets involved. When we start fixing complement, oh my goodness, things go bad. Complement 3, we're getting lupus cerebritis. Complement 4, lupus nephritis. Complement 5, antiphospholipid antibody syndrome, right? So when we add complement in the mix and complement starts going down, it's adding kerosene to a gasoline fire of autoimmune disease. So how can we fix this, right? So what if we used CAR T to target bad B and T cells and get rid of them, right? Specifically, the CD19 marker. That seems to be the cluster of differentiation. If we target it, that will help with autoimmune disease. There's lots of others out there, and I think, a pathway to the future, but for right now, CD19 is the one I would remember for autoimmune disease. All right, so the big question is, how does CAR T work, right? We use this fancy acronym. It's a complex treatment. All right, so we take the leukocytes out, the bad humor, and then we give new leukocytes back. Your own leukocytes, or we use a donor, or umbilical cord leukocytes. Then we take a virus, and we don't call it infection, we call it transfection. We take a virus to insert the CAR, or we use CRISPR editing. We'll talk about CRISPR editing to do the same thing. The CRISPR editing does it much faster, right? Why not speed up a process, especially if we want to make it commercialized and make it available to more patients? Sure, we have another process for that. So then we're looking at multiple science endeavors to make cells better for patients for treatment. So we expand in vitro the leukocytes. Then we've got to get rid of the additional bad leukocytes out that are misbehaving as B and T cells, right? So we have a protocol. We give cyclophosphamide, fludarabine, get rid of the bad T cells, lower the ones that we're trying to attack, and then we infuse the CAR T cells and see what happens, right? So we'll talk about that more in detail as to what happens. All right, so CRISPR. All right, I sold my stock, so no longer, it's no longer a conflict of interest. So what does CRISPR stand for, right? We want to, acknowledge we know what the acronym means, right? But everybody knows CRISPR. So it's clustered, regulate, interspaced, short palindromic repeats. All right, so what does that mean? All right, we identify this cool Cas9 protein in bacteria, right? And it cuts DNA. So we mix a cell with the guide RNA that we want, or we want to target cutting, has the Cas9 protein in there, has a little linker, cuts the DNA, reinserts the DNA you want, and we seal it back together. So we do genetic modification, right? It's Jurassic Park stuff. It's exciting, but a lot of implications. And we've talked about it, for the potential for sickle cell, curative and amyloidosis, right? Diseases that are invariably fatal or have high mortality, right? But there's a lot of ethical questions with altering genetic material. So I'll leave it at that. We have ethical questions, but when we're out of options, what do we do ethically when we have a treatment option that could change lives? That's a personal question, but I think it will come out a lot in the future as we're using these technologies. All right, so we talked about the case report, right? So guess what? The same group is like, oh, it worked once. Let's see if it works in a larger cohort of patients, right? But it is limited technology, very expensive, off-label use, right? So 8 lupus patients, looking at it, we get the same markers. Our activity score system goes down dramatically. Protein goes down, complement comes up. They only check complement 3, and the double stranded DNA goes down, right? So it seems to work across a wide breadth of lupus patients with complications. How about systemic sclerosis, right? Really rare disease. So getting a cohort of 4, that's pretty good. Although they do have a cohort of, I think, close to 20,000 in Europe that they follow. But, hey, 4 is pretty good. All right, so what are we looking at for that? Okay, we look at this, we call the U-star activity index. All right, so there's a lot of components of the U-star. The big components that we can look at clinically, right? Decreased DLCO, which we talked about last week with pulmonary hypertension. Also get decreased DLCO with interstitial lung disease, right? So that's a good marker of a lot of things going bad in the lungs, and increased CRP. Those are our 2 most objective findings from looking at systemic sclerosis. And of course, you're like, what's the Rodnan skin score? Okay, we'll talk about that. So it's a pinch test. Pinch all over the body and see how tight the skin is, right? Really scientific, okay? So I've never done this personally because in my training, I was told, don't do this testing. It's really inhumane, but we still use it for trials and things like that. It's similar to the tender points of fibromyalgia. We don't do it anymore. It seems really cruel and unusual. But the skin will actually soften over time with aging or disease progression regardless. So it's not a very scientific, accurate model. But we still cling to it because we don't have anything else, right? We're hanging our hat on a DLCO and a CRP. So there's still some trials out there where we're pinching skin and seeing how hard it is. But really what we're looking at is deeper tissue involvement. But we have what we have for improvement. All right, so when we look at, using CAR T as a broad application, right? Really, there's some risk. So we can have cytokine release syndrome. It can affect the brain with immune effector cell associated neurotoxicity syndrome, or ICANS for short. Everybody can remember ICANS. It's a little bit easier. And we look for both after the CAR T cell infusion. It can also cause some significant myelotoxicity, right? Neutropenia or lymphopenia afterwards, which really then the question is what to do with it. And it seems like the consensus is mostly monitor for about 20 days after T cell therapy. But I'm sure there are hematologists and oncology friends, online can also comment on what else there is to do for severe myelotoxicity. So the cytokine release syndrome, right? They list the lower incidence, 2 to 12%. In a trial of multiple patients, it was about 60%, so a little bit higher than what's purported. Now there's some product variability. I think there's at least 6 commercial products out there right now, if not more. It's a growing field. So I think as we look at purer products, better products, that incidence may decrease, but definitely occurred in Emily, right? We know what to do. So it can occur. And I think folks are not very hesitant to give treatment if it occurs. Have some flu, all the way up, flu-like symptoms all the way up to SIRS. And then how we treat it, if it's mild, we do the usual things that we do with infusion reactions. Give you some antihistamines, give you some antipyretics, give you some IV fluids, hope for the best. Or if it's severe, we give steroids and tocilizumab, which will work. All right, so the ICANS. So this is a spectrum of neurologic involvement. And I think with cancer, a lot of folks aren't hesitant to give steroids at all. So it occurs a couple days after, has a grading system as well. But if they're not getting tocilizumab, 1 to 2 doses of dexamethasone doesn't seem to work. Or if they are getting tocilizumab, we're probably giving steroids anyway. So give them 5 to 7 days of steroids. Myelotoxicity can last about 28 days. That's the big take-home message from that. What to do, I don't have a good answer on that. But I feel like it's monitored at this point in time. So when we look at treatment, right, timing is everything. So we've talked about that. You have to be sick, but not too sick. Are we aggressive at using it too early because it has some risks? Sure. But when do we use it? And I think that's a different question for every patient. There's other caveats. We got to stop treatment, right? We got to stop steroids 5 to 7 days before. DMARDs at least 2 weeks or 5 half-lives. And we have some DMARDs we can get rid of quickly. Give you some leucovorin, which is just potent folic acid to wash out methotrexate, cholestyramine to wash out leflutamide. So we can get rid of some of these quicker, but those are our more potent, medications. Rituximab, if it's given, it has to be given at least 122 days prior. That's a good long time. So there's this wait and see, right? All right, we're giving a therapy. We're waiting in tongue in cheek, maybe giving you some steroids, maybe giving you some DMARDs. So timing is different for every patient. The vaccination update, it's not real clear as to what to do. All right. So I have some data on that, but not a lot. They definitely say no live vaccines 6 weeks prior and no new vaccines 6 months after treatment. So timing of therapy, right? And this is kind of what we talked about. Again, you got to stop drugs, deplete the lymphocytes. We deplete the lymphocytes and give them cyclophosphamide and fludarabine. Guess what? The immune system goes down with the autoimmune response because we're crushing it. And then we give the CAR T infusion and then wait and see, which is a while, right? Before we can give something else. And then, there's exit strategies and also different generations of CAR T too, which we won't get into. That's going to get too in-depth for this, forum, but there's things that we can do, but really it's a wait and see after we give treatment. So some data on vaccination looks like for the most part, vaccine status and immunoglobulins are maintained. There's some that go down some, but for the most part, you are retaining some of that memory from vaccination, right? Hot topic measles currently, especially because it's a live virus, right? So seeing a lot of risk there. So what are the pros, right? We have treatments. They're off the shelf. They affect the B cells. They affect other things, interleukins, what have you. We can get them. Pretty low immunologic risk. They're not crushing the immune system. They've got a short half-life, but they don't get to the areas we need to get to. B cells are hiding from us, and then bad things happen when the B and T cells hide from us in the skin organs, right? So what are the advantages of CAR T? We get prolonged remission. Now, again, it's new to us for use, but we're seeing 2 years of sustained remission with all those markers that we've seen not coming back. So is this a soft control alt delete reset of the immune system rather than a hard delete? It may be. How long is it going to last for? Can we re-challenge patients if they had it once? These are big questions that are on the horizon. What are the problems, right? We talked about the side effects, a lot of side effects. We got treatment for that, which is great. We give you more immune therapy, wait and see. That's awesome. And, tocilizumab works, which is great. But there can be some fatalities, and I'm sure there's more reported, but none of the patients in the case report cohort died, which is wonderful. And the therapy is getting better and faster. But it's expensive, right? Now, is this cost justified for a patient with bad lupus who's going to wind up with a kidney transplant and other things? I think so. Or, 5-10 years of a B cell therapy that we, on average costs, $150,000 to $200,000 a year. That adds up pretty quickly. Don't know if the cost is justified, but it seems justified to me, especially if we're able to achieve remission that's long-standing. And we can't really deliver it to all patients at this point in time, right? And that's our big constraint, right? A lot of this is coming through bone marrow cancer centers where we don't have infusion centers that do this regularly. So we're limiting our patient selection to the worst of the worst right now. And not immediately available. And we're working on that with, donor leukocytes and utilization of technology we have at hand. So what are we doing here? So we have one allogeneic study that's in the process of approval at Rocky, which is terrific. We want to bring the technology on board. We need our friends in hematology and oncology and bone marrow to help us out with that because it's not a product we're familiar with. We have some rudimentary knowledge of the side effects and risks. The monitoring, visits, follow-up, that's going to be multidisciplinary in nature. So these are complex, trials. We have the potential for another study. We've been asked by another facility if we can contribute. The trouble is we're just a limited resource at this point in time. But I think a lot of people right now are thinking, well, this would be great for multiple sclerosis. This would be great for refractory inflammatory bowel disease. What about myasthenia gravis? What about type 1 diabetes? There's a lot of applications out there. And I really want to make you all aware of what we have for those patients. And I'm sure that, the clinical trials through NIH or otherwise are going to come. But I want to give you the knowledge of what I think is an inflection point in medicine as to a change that is going to affect the majority of specialties. And even if it doesn't affect our specialty, right? I'm sure infectious disease is listening. We're dealing with the side effects and complications of current therapy that can be pretty terrible. The severe fungal infections or bacterial infections, those are severe with the treatments that we have on hand, and especially more severe if we go the route of organ transplant or bone marrow transplant for patients that are refractory to everything else. So I like to refer to it as bag lunch rather than take-home points. But what are we taking home from this lecture today? So B and T cells work together, right? They're equal badness with autoimmune disease. And then if we're producing antibodies that fix complement, things get even worse. Our current therapies are okay, right? We've reviewed them, but sometimes we don't even know what we're doing. We hope that it helps. It seems to help. We have patients that come back where we can't help, but we want to. CAR T therapy, it's an emerging therapy. It's going to affect a lot of us who deal with autoimmune disease. And I think will not only put patients in remission, but also provide a great therapy, perhaps earlier in disease when we're not out to our last straw. Always give out my cell phone. I get calls. It's surprising. I think I got a call from UCLA last time we did the ILD lecture. It's quite surprising. And they saw my lecture and they're like, I figured I called. I asked them, are you Baptist or Norton or where you at? They're like, no, we're at UCLA. We saw your lecture. I was like, oh man. So anyway, but availability is always important. And we're always happy to field calls with unique questions. So it was great, but didn't expect that call. And these are all my kids. And then two of my colleagues, Melissa and Tony, who went through medical school with me, the Army, both also Iraq veterans. We try to get together once a year, bring our kids together, and this is on the Eastern Shore. But again, be a mentor, be a friend. Dr. Williams is going to agree. The more friends you have, the more you are a mentor, it's going to decrease your cardiovascular risk. So it's good for everybody. That's all I have. We'll open for questions.
So that's wonderful. It's a great review and opening up a myriad of possibilities for so many diseases. So what does it take? And this, I know this is probably a good discussion or a panel discussion with our oncology folks.
Oh, I'm sure I'm going to get some calls, Dr. Williams.
Exactly, but
there's going to be a list immediately after this.
Right, exactly. They're going to come with all the diseases that have any, I mean, there are a few that went on the slide that I know were important. I mean, autoimmune thyroid disease, Evans syndrome, I mean, pernicious anemia. I mean, if we could just remove all autoimmune diseases, but that's the long future. The near future would be, what does it take to scale up and double our availability and that sort of thing? It's probably a few $1 million, but that's the kind of thing that's in reach if we're really going to have a population. And has anyone taken on the task of just grabbing every disease? That is, we could actually go into Epic, use Slicer Dicer, put in all the diagnoses that are relevant, and see what our population is, and then have someone reach out, start protocols.
Right, and I think this is the big point of this lecture. And I wanted to give it last year, but we got very involved in the ILD and starting up that program.
Mm-hmm.
I was a little bit delayed in reading the first case report. I want to say it sat in my journals for about a year. So I want to say I read the 2022 and 2023. I'm like, oh, that's interesting. This seems neat. I definitely read the 2024 with the case series last year. I'm like, oh man, this is the stuff. But I agree, right? So other people, and this is tough. I can't do a literature search in neurology and all the other specialties to see what's been going on. But I can tell you they did have an interesting study for myasthenia gravis, and they tried not doing the lymphodepletion beforehand and just giving several courses. So they're getting experimental to see what happens. And they had mixed results with that. But other people are trying it for the patients that frustrate them. What it is required to build up, I think we're on the right step, right? This is cutting edge therapy. Dr. Sarapi is working hard to get one clinical trial. There's a product formulation that bone marrow transplant is comfortable with, but then there's a lot of startup companies that may not succeed, and so we're going to focus on that first. And I think it's going to be a build long term. I think once this becomes more standard, we're going to see, NIH getting involved with clinical trials in multiple sites, right. Depending on funding, things of that nature. But I think it's a build. What we need to get started, we always need more to build more. And that's a question of how much and how long. And, I think the start is we have one. And, we have to be a little bit limited on the patients that are more end stage rather than they have moderate pulmonary hypertension, it's kind of controlled, or moderate interstitial lung disease is kind of controlled. The lupus is okay, they're not on dialysis yet. Mm-hmm. But I think as we build, and I think as the additional technology helps us facilitate that process moving faster, we can shift that curve to the left and do it for these folks that have moderate disease or other diseases that may not necessarily be life-threatening, but very aggravating. Bad inflammatory bowel disease, if it's not fistulizing, but they're in the bathroom all the time, can't work, having bloody stools. That's very, non-conducive to a normal adult life. But yeah, I think it's coming, and I'd love to say, that we're rushing in and getting 100 patients in, but I think that's not feasible right now just because of financial constraints, product availability, and then you're getting multidisciplinary stuff. But we've already opened talks with bone marrow and trying to facilitate a way forward so that we can get these very bad patients who have bad disease, not bad patients, it's patients with bad disease taken care of sooner rather than later.
Sure, I think we definitely should include our IBD. It's a huge.
I'm sure Dr. Worth and all the other folks are listening. They're like, oh my gosh, the refractory, gastroparesis where we're using IVIG for. I'm sure they're excited, right? And that's probably, especially with our other diseases, you're getting the immune system where it's high with the lymphocytes in the colon.
So any other questions in the room? I know Dr. Castor had one.
Oh,
No, go ahead. No. So just like, as we are concerned with our other biologics, like we like before doing the biologic, we do TB testing, hepatitis, and then during like the treatment, we are concerned about pregnancy, malignancy. Any data about those like areas from what you reviewed?
You know, that's a good question. I think for the most part, the patients are selected already been on immunotherapy. I mean, that's what we're looking at with the lupus and systemic sclerosis and myositis patients. So they've already been tested for hepatitis and tuberculosis. I think, the pregnancy risk, I don't know about the long-term risk when we affect the B cells, but acutely, I would imagine it's not good. And it's going to be fatal for giving Cytoxan to someone who's pregnant. So that's, that has to be ruled out. But when we're dealing with, like we talked about, the problems with Cytoxan, right? Trouble is when you have a 20-year-old who's real sick, who's going to wind up on dialysis, kidney transplant, you have to have that discussion, which I've had with patients. We're going to be giving you Cytoxan and some treatment that may sterilize you, but it's to save you, and that's a difficult discussion that we have. So yeah, I mean, I think monitoring, like I said, the vaccine stuff, I don't know. I think the safe point is wait 6 months and then probably revaccinate. I think that's, no one's going to argue with that unless, they don't want to get repeat vaccines. And I would say it's probably okay, but monitoring, I don't think we're selecting patients that haven't been monitored for those things. It's going to have to be a discussion about pregnancy and pregnancy risks because we're going to be giving cyclophosphamide. That's just going to be part for the course. And I guess we have to anticipate we're going to give them tocilizumab as well because of the high rate of reaction. So we should have all that screening up front.
Yes, we'll start with Dr. Levinson, our researchers, former retired researcher, says, thank you, very good info, said, very clear talk. Are the target cells obtained from the bone marrow? Could they be obtained from the skin where the cells are quote unquote hiding?
For right now, what my understanding is, it's a leukapheresis process. So they're obtained from the peripheral blood with the donor or autologous, and I don't know how they extract them from the umbilical, but I think those are cell lines that they expand. But it sounds like mostly peripheral. I don't have details on the umbilical cord.
And then Dr. Castor from nephrology says, great lecture, very exciting area of research and excited that U of L will be participating soon. One of the biggest hurdles is the inpatient stay and close monitoring at beginning of therapy. At this time, we don't know how durable the remissions are. How long do you think they need to last? 2 years, 5 years, 10 years to justify the resources?
So the current data they had, I'm sorry I didn't expand upon that on the slides, was 24 months. So you're getting sustained at least 24 months. I just yesterday got a similar case report to the one we discussed from Cleveland Clinic, almost cookie cutter, except other bad things, avascular necrosis of the hips, lots of other problems. So even worse, sustained remission for 24 months. So I can tell you, it looks like at least 2 years, which is our cutoff for most clinical trials for systemic sclerosis. Lupus trials, particularly nephritis, I can't speak to how long the longevity is, but I think that's the big question that's raised is, we give it, we know it's going to work for 2 years. Can we give it again? It looks like it's been done for myasthenia gravis with not a lot of problems and really not even doing the lymphodepleting with, potent chemotherapies. So it looks like we can give it again. There's probably not a risk, So I think that's perhaps the way of the future is if it reoccurs, we can give it again. Or, if they got it, their own leukocytes didn't work as well. Perhaps a donor is a little bit cleaner with a cleaner cell line. These are all theoreticals. Can't tell you, but at least the data now supports at least 2 years of complete remission.
Dr. Emmons would like to know, says, given the result in cancer trials with longer-term suppression of the abnormal B cell population, the result is autoimmunity should be longer. So that's a comment more than a question, I guess.
Yes, thank you, Dr. Emmons. Yeah, I mean, we have what we have, right? I mean, this is kind of case reportable and started in 2023. So you're going to get, well, probably 2022 if they had the case report and data for a year. So, really we only have 3 years of knowledge of how this works. And that will come. When we use the TNF inhibitors, we couldn't guarantee anything or long-term remission. Now we're saying, oh, yeah, that's great. You can take it forever as long as you don't have problems. But thank you, Dr. Emmons. Like I said, I think it's a control-alt-delete reset of autoimmune disease that's going to be, have a great longevity.
That's the last, that was the last, well, actually said, he added, the results in resistant autoimmune populations have been remarkable, especially renal refractory lupus. So.
Yeah, and that's what we kind of saw, at least, 10 patients, just case report series, it's gone, right? And that's, we've been playing tiddlywinks for lack of better reference with what we've been doing with kidney disease. Some of that works, some of it doesn't. If it doesn't, then we're doing that same protocol. We're giving cytoxan, we're doing organ transplant, dialysis. So, I think it's wonderful, and I think Dr. Jacobs always jokes, they're changing the gut microbiome, they're coming out with a new therapy, you're going to be out of a job, Dave. And I'm like, that's great. I have other career plans. If rheumatic disease is cured, that would be awesome. I could not be happier if this changes what we do, especially how limited we have in resources, Then we could take care of gout. That's still our biggest problem in the US, right? Dr. Saraki I can do some damage on gout.
And then Dr. Evans followed up, said this will get cheaper in the future. Economies of scale and auto versus also will change the economics. Currently, autologous products rule the day. Allo, he meant to say allo. Yeah. Auto versus allo is what he meant to say, I think.
Yeah. So, I think it'll change. And the price point is not terrible. We're looking at someone who may need 30 years of biologic therapy that costs $100,000 to $200,000 a year. That adds up quickly. Same thing when we talked about, oh my gosh, there's a lot of costs for, using CRISPR technology to change the course of sickle cell. When you look at the hospitalizations, comorbidities, problems that ensue with sickle cell in particular, those add up to cost justification, usually within a year or two. But this is an easy sell for me, but to insurance, the US populace, those on Medicare and Medicaid and taxpayers, it's upfront for long-term benefit. It's always a tough sell, but if things get less expensive over time, I'm always happy.
And they will. Right?
His last
No, I would take it all. I got nothing after this. Dr. Williams probably has stuff.
Now he just says allogenic CAR T will be produced at scale and become more like a drug than a bespoke product.
And that's what I think, right? We're having a designer drug, although it's new technology that people aren't familiar with. And that was part of the intent today, is familiarize you with things that are coming. And we've already identified, right? If we can get a product that we can get off the shelf where we don't have to take your own white blood cells, speeding up the process. If we don't have to use viruses to transfect the CAR T itself, and we can just cut the genetic material with Cas9 and CRISPR technology, speeding it up. So I think, the great thing about this technology and treatment is it's combining all of our specialties as a teamwork in medicine. A lot of our knowledge from not only infectious disease, but also technologies that are available. People are working together. It's great. And guess what happens when that happens? We all get heart healthy. So that's wonderful. And that's why I'm so excited. I think it's a great team effort. I appreciate everybody weighing in online and being present today.
Yeah, that's it.